Welcome to the Seminars in Clinical Governance and Ethics. Today's seminar focuses on one of the most important responsibilities in clinical practice: consent for surgery involving children. When children are involved, consent must always be grounded in legal and ethical principles that prioritize the child's best interests. Healthcare practitioners carry the responsibility of ensuring that consent is informed, voluntary, and specific to the procedure being proposed. This includes clearly explaining the risks, benefits, and available alternatives in a way families can truly understand. Today's discussion will help strengthen your confidence in navigating these complex decisions with clarity, care, and integrity. We're glad you're here.
Yeah, colleagues, it's another brand new week. Yes, we are just, 40% into this new week. And I am so excited to host you this evening. And we are looking into our seminars in clinical governance and ethics. Very important series because as health workers, we are always serving people. And wherever you are helping people, it's possible that you can become a little bit bigger than the person you are serving because they are coming to you in need. Now, we always have to make sure that the healthcare, the service, the way we care for our communities, it is always within the legal frameworks in this country. It is also ethically provided, and at the heart of it is to ensure that every single interaction with our patients, our communities, it's an interaction of respect where we are responding to their immediate healthcare needs, but also the non-healthcare needs like what? Privacy, confidentiality, dignity. If you can embrace such principles, most of the time, you will get it right. We don't have to give the intervention at all cost. We always have to consider the rights of the people we are serving. So today, I am not alone. I am with my dearest Dr. Munyazi Wakwinda. He is not new to the platform. Last year, we had a series looking at some of the HPCSA regulations, that was a challenging one. Me and him, we know why. Because after that we had some afterbirth issues, but there's nothing worthwhile that we do in life without challenges. Actually, if you get challenges, you know that you are on the right track. It means you are pinging on some person's nerve out there, you know. So yeah, Dr. Quinda, can you hear me? Just to say hi to the colleagues as I introduce you.
Good evening, Dr. Mawel.
Are you
You
well?
see, I will stay away from such things. I don't want any more trouble. So good evening to you and good evening, colleagues, and thanks again.
Yeah, that part is known by me and you. So really, let's leave it
Exactly.
as is, you know. But yeah, colleagues, let me take a few seconds just to introduce Dr. Quinda. He has a huge biography, but I think well, I've come to know him personally as someone who's very friendly, someone who likes developing himself, especially in all areas. You know, if you look at him spiritually, he's a spiritual father, he is a pastor. You look at him in terms of leadership, he has operated and continues to operate at a rather, you know, high level. Even this afternoon, he was telling me about his growth in the legal and governance areas and where he's heading. And I was like, yeah, no, he is not stopping, you know, to grow himself. So I'm really appreciative of that relationship which he has now with the platform, where now he's an instructor and he has at his interest to build our capacity as health workers to appreciate the legal issues in our discipline, and importantly the ethical issues where, you know, right and wrong, there's a thin line. It depends on how you interpret the situation, you know. But he is a medical practitioner, he is a specialist in family medicine, he's a qualified medical practitioner. He has studied health law, he has studied ethics. Hey, there's nothing he hasn't done, but currently he's the chief executive officer of the Tiamo Trust, handling a whole lot of resources from the historic issues in the mining sector and trying to do justice for those who were affected by, you know, the gold and breathing in silica and helping, you know, ending up with cancers, etc., etc. So we must really appreciate the person he has become. And like I say, you can never walk to your purpose. There's no escalator to your purpose. There's no lift where you say, five, let's go to my dream. No, but we grow to our purpose. We grow to our dreams. And he is a true testament to that. Dr. Quinda, may I hand over to you to share your slides and to take us from here. But a warm welcome to you. Thank you so much.
Thank you so much, Dr. Mawela, and really want to appreciate you and the whole team at the Clinical Care Platform for this invitation again to come and share some insights with colleagues. And indeed, I'm looking forward, Dr. Mawela and colleagues, in the work that I'm doing. Numbers matter.
Yes.
When I pay more claimants, I am a happy person.
Yeah.
And we are making history at Siamiso Trust in that in the compensation industry. In about, I can say 5 years, this week, we are looking forward. I'm just left with only 5 million to reach the 2.5 billion that we have paid to ex-mine workers and their dependents where those others have passed away. So
yes,
it's quite a very significant milestone and putting smiles back to our ex-mine workers who have built our economy to where it is right now, only to go back to their villages. Some very much sick and others have since passed away because of silicosis, and others because of exposure to silica dust also struggled with pulmonary TB and so on. So I'm looking forward to this milestone of 2.5 billion. Is a number that matters for me, and I'm happy to be part of this history. But
awesome.
Anyway, we are not here for Siamiso Trust.
Yeah, but you know what I like about it before you continue is to also help.
Yes.
You know, we have a lot of unemployed health professionals who do not appreciate that, you know, our world in healthcare is so diverse. There's so much that we do. And you sharing just one corner outside the hospitals and what is possible for a medical practitioner, it's inspiring. Yeah, so thank you so much for that. Yeah.
No, that is very true, Dr. Mawela. And one other area that I think colleagues need to also look at is in the aerospace medicine as well. Is one other area where colleagues, they also have to look that side, quite making a difference. I mean, safety in the air is very important.
When you land,
if
before you
you
land, hey, safety in the air.
if you know the German wings, you have a psychiatric patient flying an aircraft for you, then you are in big trouble. But anyway, let's get into our topic for this evening.
Thank you.
Colleagues, dealing with issues of informed consent for surgical procedures involving children. That is our topic for this evening, and I'm happy to really be taking you through this. And I'm very much intentional in terms of how I'm going to be presenting it to you. It can, to a certain extent, ruffle a little bit of feathers, but in a right way. I'm just happy that this evening it won't be serious. It will be something that is an eye-opener for you. So I'm going to put my slides on. Yeah, I think I'm good now. So as part of our just a presentation overview, I will look at the introduction, which is going to be very short, but we're going to have a few quizzes. Now, I need to emphasize that colleagues, quizzes, the statement does not mean that that is what I am saying. The statement is there to provoke your thinking and is there to establish what is it that we know about the topic, or what is it that we know about the matter that we are dealing with. So we need to take it from that point of view. So we're going to look at the law, because here, as much as consent is a matter of both ethics and law, I'm going to be concentrating on it from a legal point of view, although I'm going to touch a few things from an ethical point of view, but I'm not going to really go deep into that, which I believe colleagues are very much exposed to that. But I will really be dealing with it from a legal point of view. That's where we'll look at the law and the sources of law. Then we'll look at the Constitution provisions relating to children and consent. There's a lot of things about children in the Constitution, but I've limited myself to issues relating to consent. Then we will look at some statutory provisions, that is the Acts of Parliament. Then we will touch on common law, which basically also deal with the requirements from an ethical point of view. And then I will just make a reference, of course, as part of that, to the relevant booklet of the Health Professions Council of South Africa, where you can find more information on consent forms. Then we will look at the consent forms now, issues of consent involving children in terms of Section 129 of the Children's Act. Then we also look at the social, cultural, and religious practices requiring consent. When I was doing my preparation, I realized that this is one aspect which is usually forgotten, even from an academic point of view. We only concentrate on Section 129 and also Form 34, which I'll deal with later on. And we forget about the social, cultural, and religious practices that requires consent. Then we will look at the list of consent forms. Now, this is very critical. And when we come to this point, I will want colleagues to be open-minded, because this is where really I will be providing guidance on how you can change your approach for consent procedures, or the way you obtain consent for surgical procedures involving children, to an extent where if you are a manager, you may need to really go and relook at the way you are dealing with matters of consent involving children. If you are a practitioner, go and influence changes in your area of practice. Then I will be concluding with two quizzes at the end, quite very interesting. So let's move on. colleagues, consent for surgery involving children is a complex matter, and you will understand children are not like adults. They are legal minors and have limited capacity to act independently, and some of these things we will clarify later on through our presentation. And in practice, what I have observed is that informed consent procedures involving children are usually not different for those involving adults. You find that if I were to ask you really, are you not using the same consent form that you use for adults, irrespective of the procedure? As I will make it very clear that it also depends which procedure, and it also depends who are you dealing with in front of you in terms of what should be contained in that particular consent form. But many of you will agree with me that really there is no difference between the procedures that we follow in obtaining informed consent between adults and children. And it is for this purpose that in this lecture, I aim to provide a guidance to healthcare practitioners, all of you are here, who are involved in performing surgical procedures on children, including those at a management level, as I said earlier on. You can use this guidance to go and change certain things and influence certain things. I always say, and I will make it very clear, if some people do not know, you may get into trouble if somebody can take you on based on the kind of a consent form that you used for a particular procedure, especially when it relates to children. Now, let's go for our very first quiz. And here is a matter of a true or false. And the issue is the Children's Act of 2000, Act number 38 of 2005 is the supreme law for consideration in any matter concerning children in South Africa, including matters relating to informed consent for surgical procedures, as it gives effect to certain rights of children as contained in the Constitution. Now, is this statement true or false? Can we get your response to that?
Yes, feel free to comment in the chat there. We are looking, we see truths. Thank you, Siluvangi. Thank you, thank you. Lots of truths. Zero false.
Yeah, I'm seeing lots. Yeah, I can see lots of truths, and yeah. No, it's true. So we can conclude that colleagues believe that this statement is true, and hence, as I said earlier, the reason really for the quizzes is just to establish the baseline in terms of where our knowledge is. Now, the key word here, colleagues, in this quiz is supreme law. That is the key word there. I can see the rest of the things, but you need to understand that in the Republic of South Africa, you have got one supreme law, and that supreme law is the Constitution of the Republic of South Africa. Now, that is the key word here. And every law, every act is subordinate to the Constitution. That is where we start. Most of the acts of Parliament are giving effect to the Constitution. If you look only at the Bill of Rights in chapter number 2 of the Constitution, you can count so many legislations that have been made to give effect to the rights that are enshrined in the Constitution of the Republic of South Africa. Now, it's very much important, colleagues, to understand that when you talk about supreme law of the land, can only be the Constitution. On that note, let's move on now to what is happening now with my slides. Let me just do something here.
No, click anywhere on the slide, then you should be able to move.
Okay.
Yeah.
All right. Oh,
Yeah.
there we go.
Yes.
Thank you so much, Dr. Mao. Now, colleagues, let's look at the law and the sources of law. Now, you need to understand that, and there's a point I like here in the definition of a law, that law is a comprehensive set of legal rules that govern human behavior or conduct in society, and failure to adhere to such legal rules may result in prosecution. And I like the word, this directive word that says may result, because many a times it depends on whether you are caught or not. I mean, I wonder how many of us here can say we have never broken the law. It's only that sometimes you break the law and you are not caught. So it does not mean that you will be going like that for the rest of your life. So even when it comes to this issue that we are dealing with this evening, you may just need one person who can take you on, and you may realize at that particular time that in fact what you were doing was wrong. You were not adhering to the legal rules. You were not adhering to the law that governs the area in which you are operating. Now, from the sources of law, we have the Constitution, as I said earlier on, which is the supreme law of the land. You have the statutory law, which are laws created by Parliament and referred to as an act of Parliament. Your provincial ordinances and municipal bylaws at a local government level. Then we've got common law, which is Roman Dutch law, which was imported into our legal system in our country when we were still a Dutch colony, and has significantly been influenced by English law. Then we have got case law. Our last topic, we're really looking at judicial precedent, which is a reliable source of reference for all important reported cases dating back to 1947 to date, and also include peer-reviewed academic writings, including books. Now, also, we do have customary law, and there is a lot happening in this case, a state of customary law. I just saw a judgment recently, I think now in January, there was a judgment that was released in terms of when people now change their arrangements in terms of matrimonial property and so on. Now, this is law not considered a source of law of general application, as it is deemed to apply only to those who choose to be bound by it, and is applied by the courts provided it is reasonable, has long been followed by that particular culture, and does not conflict with the Constitution or any other law. So Constitution or any other law will come above the customary law, and that is now at a level of how we practice our cultures. And I just made this important point based, of course, on what we just said on our quiz, that the Constitution remains the supreme law and all other sources are subordinate to it. So whatever you see in the Children's Act is basically giving effect to the provisions of the constitutions, especially the Bill of Rights. Now, let's look at the constitutional provisions concerning children in relation to consent for surgical procedures. And I just picked up 4. The first one being Section 10, which deals with human dignity, which need to be respected and protected. Then we have Section 12, which deals with freedom and security of the person, making decisions concerning reproduction and security in and control over their bodies. Then we have got Section 15, which deals with freedom of religion, belief, and also opinion. And it will become clear as we go along how relevant these provisions of the constitutions in the Bill of Rights are. Then we have Section 28 really that deals specifically with children. This is one of the sections in the Bill of Rights that is dedicated to issues relating to children. And of importance, it emphasized that a child's best interests are of paramount importance in every matter concerning the child. And it is where, for this purpose of this section, defines a child as a person under the age of 18 years. Now, let's also look at the statutory law provisions that deals with consent for surgical procedures in children. We have the Children's Act 38 of 2005 and the regulations made in terms of this act. We're going to go into the details on this one. But just to touch a bit, because we're not going to go deep into this, we're just going to touch on it, is the Choice of Termination of Pregnancy Act 92 of 1996, especially Section 5, subsection 2 of that act, which says that no consent other than that of the pregnant woman shall be required for the termination of a pregnancy. For the purpose of this act, woman means any female person of any age. If she is a minor, she should be advised to consult her parent or guardian, though termination of pregnancy should not be denied if she refuses it. Just a week ago, I did receive a call from a colleague who was concerned that somebody terminated the pregnancy without the parents knowing, and wanted to know if the doctor did something wrong by terminating the pregnancy without the consent of the parents. And I used this provision to clarify that no, it is not needed. Of course, the doctor can advise the child, and it's always advisable that if you did advise that child to consult a parent or guardian, make a record of it, knowing very well that if the child says, I don't even want my parents to know, you cannot deny that child a top. Then we do have the Sterilization Act 44 of 1998, where the minors may only be sterilized if their lives will be jeopardized or their health seriously impaired by a failure to do so. And in such cases, a sterilization can be carried out if the parents or guardian have consented and an independent medical practitioner, after consulting with the child consent, makes a written statement that the sterilization will be in the best interest of the child. So you can see, colleagues, at the end of it all, as emphasized in terms of the Constitution, the best interest of the child is of paramount importance. Then we do have the National Health Act, especially Section 6, that really deals with the information that has to be provided, which has to be known by any user of the healthcare services, even including things relating to preparation for surgical procedures. Now, common law provisions for a valid consent, you need to look at the capacity, that is the competence of the person. Now, is the person capable of understanding the information, appreciating the consequences, and making a reasoned decision? And this involves being of a legal age and mental soundness. That's why you will see in the Act, you also have to look at the level of maturity of the person in understanding the information, appreciating the information that is being given to them. Like we're going to talk about issues of 12 years, it also depends whether somebody is of enough maturity from your assessment that they can be able to give that consent. The issue of information, which has to be sufficient, but more importantly, clear. You can't be using medical jargons. You need to come to the level of the patient about the nature of the procedure, the potential benefits of doing that procedure, the risks and alternatives that are available, so that the person is in a position to make an informed choice. And that is where the word informed consent comes from. It means a person has been provided with enough information. Of course, when I was doing my specialization in family medicine, my dissertation was on informed consent procedures for women undergoing cesarean section in one of the hospitals in Limpopo. And it was quite very clear that really information is not provided to these women before they go for the cesarean section. So this is where really we have got a challenge. I had my own personal experience when way back in 2013, when I was going for an eye operation. And the nurse just came to me, and to be honest with you, I was so anxious because I was not sure, am I gonna see after this operation? Am I not gonna go blind? And if I'm gonna see, I wanted to know how long will it take for me to see again? And I wanted that information. Then a nurse came and said, you must sign here. I said, what am I signing for? Is there somebody who's going to explain to me what is going to happen? Somebody that I can also ask questions to be clarified so that when I go for this operation, I am sure of what I'm going for and what is it that I must expect from this operation. And the doctor had to come. And remember, when I went for my operation that time, I was even a vice chairperson of the Medical and Dental Professions Board. And I was seeing it with my own eyes how colleagues are in practice. The issue of voluntariness, consent must be given freely, without pressure, without manipulation, or without even intimidation. Somebody must voluntarily give their consent. They cannot be coerced. I remember we once had a scenario of a lady who had an ectopic pregnancy, and she refused to go to theater for an operation. We tried to speak to her. She said, no ways, I'm not going to theater. We tried our level best because we knew it has ruptured. She's bleeding. We are resuscitating her with fluids. Now we need to move into bloods, but we need to arrest the bleeding. And this woman did not want to consent. And we had to even call the parents. We even, the father had to drive from Gauteng back to Limpopo to come and talk to her. And it may look like, some pressure exerted there. But we thought, hey, this one does not need, can we just use this? Because we knew if really we don't go in, we are not sure if her life is going to be preserved. So those are real challenges that you will face, but have this basic knowledge that it has to be voluntary, not coerced. No one should be manipulated into it. No one should be intimidated into it. Agreement. Now, this is linked also to the right to refuse that treatment. In terms of the Children's Act regulations, there are forms that have to be completed in order to record the consent process. But of course, you can still get the consent without completing a form, but it is advisable. It is advisable that you use a form, have those signatures there, but when it comes to children, as I'm going to demonstrate later, you don't have a choice because all these forms are prescribed in law. And they require you to put your names, they require you to put in your signature into that form. So there is no other way to go about it. So when it comes to children, you have to use that form. Then let's move on. From an ethical point of view, booklet number 4, seeking patients' informed consent, the ethical consideration from your regulator, the Health Professions Council of South Africa. it also guides you in terms of the procedures that you have to follow. Now, let's go to quiz number 2. These quizzes, colleagues, are quite very simple. It's true or false. We just establish how many truths are coming through and false is coming through. Now, listen to the scenario very carefully. A girl child of any age may consent independently to surgery if the procedure is a termination of pregnancy. And this is the second part. And should there be a complication, because it may happen that somebody is completing their termination of pregnancy through an evacuation of the uterus, but there is a complication in theater and it requires that a hysterectomy has to be performed. The issue is she can still consent independently to the hysterectomy. True or false? Can we see the answers? False, true, false, false, true, false, false, false.
This one, there's
false,
drama.
False. I can see.
There's no unism.
There's no unism. Others say it is true. Others are saying no, it is false.
Yeah, no.
False, true, true, false, false. Now, I think we can stop there, colleagues. I think majority of you, although there is drama, I'm happy about this one is different from the previous one. At least we can clarify to say, remember, colleagues, the procedure now of a hysterectomy is no more about termination of pregnancy. Evacuation of the uterus, yes, is fine. But when it comes to hysterectomy, it's a different procedure altogether. And that is where now you need to get the consent of the parent or the guardian. Any other procedure relating to the termination of the pregnancy in terms of the act, yes, the child of any age may consent, as we said earlier, independently to the surgery if it is related to the termination of pregnancy. But should a complication arise, and this is where the difference comes in. Now you are dealing with the complication which is now requires a hysterectomy. For you to perform that hysterectomy, you need to get the consent. Okay. Now, quiz number 3. Quiz number 3, again, is a true or false. The parent of a child can provide a consent for his or her child even if him or herself is a child. Now, this is a child parent. Can a child parent provide a consent for his or her child? This is the question. True or false? Can we see the responses to that? True, false, false, true. It's
I
another
expect
drama.
because of the nature of the question.
Wow. No, it's another drama. Quite very interesting, colleagues. That's why it is quite very clear that we needed this presentation, because you can see by the responses that we are receiving. Somebody says, I am confused. Now here, colleagues, maybe we should stop there. Here, colleagues, we are dealing with a child who is a parent. It's a child who has got a child less than 18 years of age, and the child of the child has to go for a procedure, a surgical procedure. And the question is, can the parent of that child, who is also a child, provide consent? Truth of the matter is they can provide a consent with the support of the parent or guardian. They can't do it by themselves. They need to be supported because they are still a child. So that is false. Okay. Now, Let's look at the consent scenarios involving a child in terms of Section 129 of the Children's Act. Now, a girl child of any age may consent independently to surgery if the procedure is a termination of pregnancy. I think we have dealt with that aspect. No one may consent to the sterilization of a child, male or female, under the age of 18. In other words, sterilization of a child is prohibited in law. As we said earlier on, there are conditions that are attached to that as we stipulated from the Sterilization Act. Now, if the child is aged more than 12 years, has sufficient maturity and the mental capacity to understand the benefits, the risks, and social and other implications of the surgery, she must provide consent to the operation, but must be assisted by a parent or legal guardian. So a child aged more than 12 years and who, according to your assessment, has got sufficient maturity and mental capacity to understand the nature of the procedure, the benefits associated with it, and the risk and the social and other implications of the surgery, can provide consent to the operation, but has to be assisted by a parent or a legal guardian. Now, if the child is less than 12 years or more than, or even where a child is more than 12 years, but lacks the capacity. So with the previous one, if you assess, you find that this child lacks capacity, the consent must be provided by a parent or a legal guardian. You don't have to have the child being involved. The parent takes over if the child is less than 12 years, or even if they are more than 12 years but lacks the capacity, then the parent or guardian has to step in. Now, if the operation is both urgent and necessary, and there is no one to assist the child, the superintendent or person in charge of the hospital may provide consent. I do know that this word superintendent is not used that much. Clinical manager, senior clinical manager, CEOs, and so on, clinical executive, and so on and so on, medical managers, whichever names is used, but somebody who can be able to assist here. If the operation is not urgent and the parent or guardian is incapable of assisting the child or cannot be found or has even passed away, the Minister of Social Development may provide the necessary consent or assistance. This is how the minister now comes in. It's when it is not urgent, whereas when it is urgent, the superintendent or the person in charge of the hospital has to step in. If the parent of the child is a child himself or herself, consent is to be provided by the child's parent's guardian. That is now our previous quiz. You need to involve that child's parent's guardian. Now, the High Court or Children's Court may provide consent or assist a child if all the other proxies listed in the section are unable to act for whatever reason. An application can be made to the High Court, and this is done, colleagues, in the context of the constitutional provisions of Section 28, where it talks about the best interest of the child being of paramount importance. If whatever procedure has to be done in the best interest of the child, then an application can be made to the High Court or to the Children's Court. Now, this one is interesting. Also, is a true or false. Male medical circumcision, whether you call it VMMC or MMC, can be performed on any child irrespective of age, provided there is consent from the parent or guardian. true or false? Can we see the answers? False, true, true, false, true, false, true. Yeah, it's another drama. This one, different views from colleagues. Interesting. False, true, 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 false, false, false. Yeah, different views on this one again, colleagues. And it again emphasizes the point why we needed this session this evening so that we can enlighten each other. It's quite very clear from the responses that are coming through. Now, just for something. Okay, no, something else. All right, let's get the answer. Let's get the answer. And the answer is really in the slides that are coming. I'm not gonna give it here. Let's go to the next slide and see if the next slide provide an answer for us. Now we look at the social, cultural, and religious practices requiring consent. Hence, I refer you to the provisions of the Constitution and how relevant they are, because there are these social, cultural, and religious practices that requires consent. Now, this is in terms of Section 12 of the Children's Act. Now, every child has the right not to be subjected to social, cultural, and religious practices that are detrimental to his or her well-being. Genital mutilation or the circumcision of female children is prohibited. Virginity testing of children under the age of 16 is also prohibited. Now, circumcision of male children under the age of 16 is prohibited, except when circumcision is performed for religious purposes in accordance with the practices of the religion concerned, and in the manner, of course, prescribed. That is prescribed in the regulations. Or the circumcision is performed for medical reasons on the recommendation of a medical practitioner. It's very interesting. Now the question is the MMC voluntary or is it something recommended by a medical practitioner based on the condition of the child, or it is done as a program, as part of us fighting the scourge of HIV infections? Then we have MMC. Now, is it lawful to perform a circumcision on a child who is less than 16 for the purpose of HIV infection? Now, if you take time and just think about the act that deals with sexual offenses and so on, at what age can a child consent to sexual intimacy or sexual intercourse? When we circumcise a boy of 10, are we circumcising him because we are preventing HIV? This child is already involved in sexual intimacy. So think about that. Basically, in terms of Section 12, circumcision basically of a male children under the age of 16 is prohibited, except for religious purposes or for medical reasons on the recommendation of a medical practitioner. Circumcision of male children older than 16 may only be performed if the child has given consent to the circumcision in the prescribed manner or after proper counseling of the child and in the manner prescribed. Now, taking into consideration the child's age, maturity, and stage of development, every male child has the right to refuse circumcision. Now, if you go and circumcise a child who does not really understand what is happening, and when they grow up, they say, I want my foreskin, where are you going to find it? So it's very much important, very much important that we are considerate of these things. And it will become very clear, colleagues, when we look at the forms, why these things are like this. The forms are going to tell you, if you go through the form, if you are using a proper form for circumcision, there is no way you are not going to stop and ask certain questions if you go through that form. But because we use the general forms for circumcision, we just go ahead and do things, and whereas the law is saying something else. So let's go on. Now, quiz number 5. Is it true or false? Simple quizzes today, but very critical. These quizzes are really showing how much we know as practitioners. In surgical procedures involving children, the consent forms used should be as prescribed in terms of the Children's Act regulations or similar. What is your response? True or false? True, false. I see more of truths here. I've just seen one false so far. It's true.
It's one of
We are
those where you
together.
think, it's one of those where you think, what's the trick? There's a trick somewhere. Why is it so obvious?
Exactly.
There must be a trick somewhere.
Why is it so obvious? What is it that I'm
you
missing
exactly
here? What
like,
is
no,
hidden?
this one, something is not right.
Colleagues, the truth of the matter, and I think I touched on this right from my introduction when I was touching on, we seem to not differentiate, in practice between children and adults to an extent where we use the same forms that we use for adults and when we are dealing with children. And it is on this note, colleagues, that now I introduce you to the forms that you need to know. These forms are forms that must be used in obtaining consent for surgical procedures involving children. And if you do not download the form itself and use it as it is, whichever form that you draft should capture the details that are contained in these forms. Form number 3 is consent for medical circumcision. Form number 4 is consent to religious circumcision. So I'm going to take you through this form so that you can see how important is it that we use the relevant forms when it comes to children. Then we have got form number 33 is an application for consent to medical treatment or surgical operation by the minister. Remember, in terms of section 129, when it is not an urgent procedure, we seek the consent of the Minister of Social Development, and this is the form that we used to apply for consent. Then you have got form number 34, which is consent to surgical operation, where the child is providing the consent. Then you have form number 35, where you have consent to surgical operation of a child by a parent who is aged below 18 years. So see those scenarios that we described earlier. And on this note, I'm going to move out of this slide. I'm going to stop sharing this slide, and we are going to look at the forms specifically now. Starting with form number 3 for medical circumcision. Let me just share it now. Let's see. I hope you can be able to see, colleagues. Now,
100%.
this is form number 3. Consent to medical circumcision. To tell you the relevant regulations, Section 12, subsection 9 of the Children's Act 38 of 2005, Republic of South Africa. This is our law. Now you can see it has got Part A. Part A deals with the particulars of a patient, where you need to record the full name, ID number, residential, postal, contact details, and the age of the patient. Now, Part B is the details of the medical practitioner administering the circumcision. Now, the name of the practitioner, address of the practice, the HPCSA registration number, and then reasons for the circumcision. Then you need to provide the reasons, because remember, it's a medical circumcision. Why are you doing the circumcision? Now, this is the part that I said earlier. Before the medical practitioner can append a signature, need to state this: I confirm that I have received sufficient proof that the patient is 16 years or older. I have explained to the patient the following: the nature of a circumcision, the different surgical methods to perform a circumcision, the surgical method to be followed, any risks associated with a circumcision, any complications associated with a circumcision, any other implications or possible consequences of a circumcision, and if there is any other information is provided there. I have given the patient an opportunity to ask questions. And when the practitioner has confirmed all these details, including proof that the patient is 16 years or older, then the practitioner append the signature and the date. Now the patient comes in and say, I am this patient. I understand that a circumcision is going to be performed on me, and that I am voluntarily undergoing this surgical procedure, understand the nature and implications, as well as any risk and possible consequences of a circumcision that have been explained to me. I confirm that I have been given an opportunity to ask questions, consent to a circumcision, but understand that I may at any time before the procedure withdraw my consent. Then the patient signs and there is a witness. Now, Part D is where you have got the assistance by the parent or guardian, to be completed in the case of a male child over 16 years but under 18. Remember, under 16 prohibited, unless there are other reasons. The parent or the guardian comes in and say, I, Munyaziwa Kwinda, have assisted the child to consent to a circumcision, and I declare that the child is over the age of 16 years, but under the age of 18 years, and is, to the best of my knowledge, of sufficient maturity, and has the mental capacity to understand the benefits, risks, social and other implications of a circumcision. Then the parent will sign. That is the male circumcision, medical circumcision. I'm not saying much about what we are doing. I'm just sharing this information with you to enlighten you to what the law requires. Form number 4 is consent to religious circumcision. Details of the patient are there, the age as well. You can see the details of the practitioner. Now, what you will note here is that because it's a religious circumcision, the reason is already there. There is no provision for the practitioner to provide reasons for the circumcision. And they say, I've explained to the person consenting the following: the nature of a circumcision, and any risk associated with a circumcision, any complications and so on, and I've given the person giving consent an opportunity to ask questions, then the practitioner signs, or the person administering the circumcision signs. Consent by the parent or guardian comes in now. I understand that a religious circumcision is going to be performed. I understand the nature and implications, confirm that I've been given, and so on. So then they sign the witness. Statement by parent or guardian to be completed in the case of a male child under 12 years or over that age but incompetent to sign the consent. The details are there. Then there is a part D, assistance by parent or guardian to be completed in the case of a male child over 12 years but under 18 years. So this is when now the person put the name, declare that I've assisted the child to consent to a circumcision, declare that the child is over the age of 12 years but under the age of 18. So we stop here on these ones of religious, cultural practices. Then we move on to the surgical procedures. Then just quickly scroll to the relevant forms 33. That is where we're going to start. So I'm just introducing you to this form so that you know what is available out there and how you need to administer consent. Which one is this one? Yeah, we start here. This is the application for consent to the medical treatment or surgical operation by the minister. You provide the details of the child, including the passport number. We do understand the country that we are. The applicant's details, your relationship to the child or official designation or other details, particulars of the person or hospital or clinic, surgery or other institute providing medical treatment is provided there. Details of the medical treatment or surgical operation, motivation for seeking consent of the minister, parent, guardian incapable of giving consent or motivation, parent cannot readily be traced, steps taken to trace the parents, attach the copy of the parent or guardian's death certificate if they've passed away, child unreasonably refusing to give consent, motivation. That's when now you are acting in the best interest of the child. Consent, refusal of consent by minister. This is where the minister comes in and so on. So that is application to the minister. Form number 34 is consent to surgical operation by a child. The child to be 12 years of age or older and of sufficient maturity and having the mental capacity to understand the benefits, the risks, and social implication of the surgical procedure. Details concerning the child, the particulars of the person, so part A, it has got all that information, details of the child and the age, particulars of the person or hospital or clinic performing the surgical operation. Then you have got please furnish details concerning the name and type of institution in the space provided, particulars of the parent or guardian assenting to the surgical operation. Remember, here the child can give consent with the assent of the parent or guardian. So you may have one, you may have two, and when necessary or desirable. And it's usually if there are two parents giving assent to that. So it's not a consent that they are giving an assent, they are assenting to the operation, but the child is consenting themselves. Then you have got a part B, which is explanation of the nature, consequences, risk, and benefits of surgical operation. Now, I, name of person seeking child's consent to perform a surgical operation, confirm that I have explained to name of the child consenting to the surgical operation, the following in a manner that is understandable to the child all those details that we described above. I've given the child an opportunity to ask questions to the above. I have satisfied myself that the child is 12 years or older and sufficient, matured, and has the mental capacity to understand. I've also satisfied myself that insert name of the parent has duly assisted the child to give consent to the surgical operation. Then you have got the signature of the person seeking consent, the name of the person seeking consent, the designation of the person seeking consent. Then the child comes in and also consent, saying, I understand the following surgical procedure is going to be performed on me. I understand risk and benefits and everything. I believe that I have sufficient information to give my informed consent and do so freely. The child signs the name of the child and so on. Then you have the parent or guardian coming in. I, assisting the child to consent to a surgical operation, confirm the following. So the same information as you can see. That is form number 34. Form number 35, consent to surgical operation of a child by a parent who is aged below 18. This is a child parent. The same details, child upon whom surgical operation is to be performed, parent aged 18 years giving consent, parent or guardian assisting the child parent to give consent. Then particulars of the person. So basically, colleagues, is the same details and so on and so on. So what I'm describing to you here, bringing to you, is that these are the forms that are prescribed in terms of the Children's Act regulations, and these are forms that must be used. If you are not using these forms as they are and you decide to draft your own forms, better do them in this manner, contain all this information, because one day you never know what may happen, and should you be in trouble, then they can open case. Of course, from the case law that we know is that it may not necessarily be a criminal prosecution of an assault of a child. Is usually treated as negligence, and it could be the issue of a civil court case. But you never know. Some people can take you for criminal prosecution, but it's important that you ensure that you use the correct form as prescribed in law. So let's complete our presentation. Let's complete our presentation. We're dealing with these forms. Let me just, okay. Let's share. All right. We are back and we are about to complete. So I just took you through all these forms, colleagues, so that now you know which form are you supposed to use. Let me put it on. Yeah, all right. Now, quiz number 6. And this one just really requires us, from what we have learned today, this is, I don't know if this is, but I picked this one up as it's called an MMC intake form. And I just captured the consent form aspect of it from G1 to G2 especially. G3 deals with the issue of the counselor or provider, counselor providing client with this information. So when you look at it, it says informed consent for medical male circumcision or assent for clients 10 to 17 years. Clients 10 to 17 years. I, the above mentioned hereby declare that I was informed and voluntarily accept to undergo medical male circumcision. I understand that VMMC is a surgical procedure that offers partial protection against HIV infection, With any medical or surgical procedure, there are risks involved. The circumcision procedure and its possible outcomes, including complications, have been fully explained and discussed with me. I was informed that I might be contacted telephonically or by mobile number supplier for follow-up. I consent for the medical male circumcision. I choose to decline if they are declining. Then signature of the client and the date of consent. Then you have got G2, which is a parent or legal guardian consent for medical male circumcision. Name and surname of parent or guardian, signature of parent or guardian, date of consent, and so on. Then the person comes in who is providing the counseling to say, I've given the client or his parent legal an opportunity to ask me questions and have ensured that they understand the information provided. To the best of my assessment, the client and or his parent or guardian are capable of giving consent and have sufficient information to make a decision about whether to proceed with HIV counseling or testing and voluntary medical male circumcision procedure. Given what you have learned today, what changes will you make to this MMC intake form, consent form? And I think you have the answer. Maybe, Dr. Mawela, we may just give an opportunity to one or two people who may raise their hands and we see if somebody can offer an answer to this one. We are about to be done, colleagues. I think it's my second last slide. Is there anyone who want to offer an answer? Okay. Change the age, somebody says. I see age 16 to 18, more information about procedure and long-term complications. Age must be from 16 and below 18 years. Okay. Yeah, I think it's quite very clear that colleagues have been following. Let's leave it here and go to our last slide. And the last slide really is also a yes or no. After what I have learned today, I'm going to change the informed consent procedures for surgical operations involving children at my area of practice. Yes or no? Can you see the answers? I'm expecting yes,
Yes, yes,
Dr. Mawela.
There's no drama.
No, we did very well. We did very well this evening. Things are going to change. Things are going to change, colleagues. Thank you so much. It shows that we have learned a lot this evening and we are expecting changes in our areas of practice. Let's go out and do so as I check out from the presentation. Thank you so much, Ndo Libuwa. Nda.
Rolibuwa. We are so thankful, Dr. Quinda. This is so empowering. Yeah, just to say thank you so much, for making it. I wanted to actually to just make sure that the Zoom people can also see us. Very theoretical. I mean, it's everything. The foundation, the theory is important, but then when you moved us into practice, now colleagues are able to test the application, and you can see why that transition from what what the theory says, and the practice, the transformation happens. And if we just come and just share knowledge without focusing on helping colleagues to transform, it means we are just ticking boxes. But this has covered the key things that are very important. So thank you so much, colleagues. Just to emphasize few things. Number one is to say that We will share the forms. Dr. Quinda has shared with me a PDF version. So tomorrow morning, the team will share with you on our various platforms. We'll also try to share it via email, which is very important. Also, for you to note that we are a membership-based platform. So it's very important for you to support the work that we do so that we are able to bring you more and more of these topics. Yeah, so do visit our website. I'll share the link later for those of you who are not members, or maybe your membership needs to be renewed. But also to remind you why this is important. Actually, we've been doing a review of the platform, and we are the largest independent CPD provider. You see, that word independence has to do with the fact that you, the health worker, are funding your own education, and therefore we are able to bring you topics that are important and relevant. We don't have to wait for someone who has a vested interest on a product for us to come here and compare product A and B the whole year, and we say this is continuous professional development. No, that is just pushing you to choose a product. What about topics which rely on your clinical skills? What about this topic on ethics, which relies on you paying attention to principles and stuff? We are able to talk about postpartum hemorrhage, things that are important and affecting women every single day. So if you're asking yourself, why must I subscribe for CPDs? You are not subscribing to CPDs. You are subscribing to the transformation you need to become a better clinician and be ready, confident and competent for the patient you are going to see tomorrow morning. And I think as a platform, that is what we stand for. And I hope that our members are happy with what we are doing. Now, you guys have sent 1 million comments. We were like, hey, what about this child? What about the traditional people? So maybe let's try and go through some of them, I had mine, but when it's like this, usually I just keep my questions aside and maybe we focus on what you guys want. So Karen says, how does one assess competency in a child? So is that thing, I think the words you used, I actually wrote it down: mental soundness, maturation, is it the age thing? An adolescent pregnancy that is unplanned? Did the child understand the consequences? But maybe let's stick to the first question so that we can go through as many as we can. Just focus on Dr. Quinda. How can you easily evaluate whether this child is competent to make consent for themselves? Yeah.
Yeah, that's why in my introduction I started by saying it's a complex area when you are dealing with children, and that is one of the things, because it really come from the way you have a conversation with a child. I think, colleagues, generally speaking, let's be honest, you have come across children who are quite very young, others even less than 12 years of age, that when you talk to them, you realize this child seems to be speaking like a 14-year-old. And sometimes you speak to a 17-year-old, you said, is this child really over? and the same applies with adults. I mean, let's be honest. There are those adults that when you are speaking to them, you think to yourself,
yeah,
it's like,
what's
I'm speaking
happening?
there's nothing really that is prescribed to say. As a practitioner, you are able to assess, and it comes back now to when you ask a child questions about the things that you are explaining. Does this child seem to understand, or they seem to be lost? So if you give information to the child and expect a feedback from the child, it's from that feedback that you can be able to assess the mental soundness of that particular child. But if it is about you just bombarding the child with information without seeking or getting feedback from the child, you are not going to assess that. So it requires somebody who will have time to talk to the child. That conversation will tell you a lot. I mean, getting feedback from the child will also tell you a lot as you interact with that particular child.
Yes, yes. And these kids, I mean the competent ones, they also have their own questions. As once the child start even asking
Yeah,
you
yeah.
questions, you sort of think, okay,
Then we
the
must
child is able
realize
to
that
follow, you know. So usually that's how I
yes.
tell, or okay, here I'm dealing with a child who's, who understands,
Mm.
what's happening. And there are frameworks out there, colleagues. We did share in some of the webinars we have had in the past. Yeah, but then how do you balance a child who's consenting for a procedure and the support they are going to need after the procedure? I think that's where health workers get stuck, because yes,
Yeah.
you are testing for HIV alone. I'm gonna give you ARVs, you're gonna come to my house. My son now knocks. Did I have tablets? Hello. What about the support that the child needs? Yeah.
Exactly. And I think yeah, I think that is where, I'm a family physician,
Mm.
and our I mean, being a family physician, you're a super GP. It's a GP on steroids.
Yeah.
And it really it really goes into the principles that we look at
Mm.
when we look at a patient,
Mm.
which you do not see with other specialties, where the patient is at the center, the environment in which they operate is at the center. Hence, you will hear us talking about doing home visits. And it's something that when you are operating with a child, those are things that you need to be thinking of. Don't only look at the patient that is in front of you or the child that is in front of you.
Mm.
Establish the support structure that is around that child, because it does not end there with you.
Mm.
When that child is going to the family, when that child is going to the community, when that child is going back to school,
Mm.
because that is one other thing that we do not. You may find that a child may not have the kind of a support that they have at home, depending on the kind of the parents that the child is having. We do
Mm.
have children really who thrived in life, not because of the contribution of their biological parents, but the kind of teachers
Mm.
that they interacted with. I mean, I know as a pastor that we also provide very significant support to lots of families and
Mm.
lots of children. So you need to explore, not only from a family point of view, the community structures that are in that community.
Mm.
The other organizations that provide support to the individuals, provide support to the community, and explore the best way that this child can be able to be assisted. So let it not end
Mm.
with that child in front of you. Think beyond the child, think
Mm.
beyond the experiences that they're going to
Mm.
have. Others, after going through that procedure, they may be laughed at by others, they may be bullied, and so on.
Mm.
Prepare them for such things. And that's why, that counseling becomes critical and important.
Mm. Mm. Awesome, awesome, awesome. So, can a hospital CEO give consent in an emergency? Basically, obviously, if it's a medical manager, the assumption is that it's a clinical person. But CEO, anywhere where they feature.
Yeah. Yeah, remember the act talks about the medical superintendent
Mm.
or the person in charge
Mm.
of the health facility. And I
Okay.
don't want to get into the politics of who is in charge
Yeah.
or who should we be appointing as CEOs of our
Yeah.
hospitals or whatever.
Mm.
But what is critical is that there is a medical practitioner
Mm.
who have determined. I always make this example, Dr. Mawera, from the civil aviation space that I also operate in,
Mm.
where the director of the civil aviation authority will designate aeromedical examiners.
Mm.
And why is the director doing that? The director is recognizing that this person is a professional.
Mm.
They've got skills, they are ethical, they are professional.
Mm.
That if I give them this task to do it on my behalf, because I am not a medical practitioner,
Okay.
but I need to ensure that a pilot flying people is medically fit. A cabin crew member is fit to perform their jobs. The air traffic navigation system officials are fit medically. Their eyes are proper. They can be able to see proper colors and so on. So I am designating this person to perform this function on my behalf.
On your behalf.
And whatever they recommend, then I take it because this person is performing a professional act. So meaning even in a hospital context where a CEO may happen to be a non-health professional, that person will depend on the recommendation of the practitioners who are treating the patient or the child to say, we need your consent, we need to urgently operate on this child. And based on that, because of the professional status of the doctor, then the CEO can append a signature.
Awesome. Very interesting. Can I ask you, why does the act refer to the Minister of Social Development and not the Minister of Health as the highest decision maker?
Yes, the issue, Dr. Mawera and colleagues. And I think I described this when we were dealing with another topic, that when you look at every act, in fact, you look at the organs of state. You have the legislative authority, which is parliament at a national level. And then you have got provincial legislatures at a provincial level, then municipality councils at a local government level. Then they make laws. Now, then you have the executive authority. The executive authority, that is where the president, the vice president, and the cabinet, where your ministers are. Now, what you will find in every act, you will find that every act has got a custodian in terms of the department or the ministry that is responsible for executing the provisions of that particular act. And that's why you will find that in the context of the Children's Act, it is under the Minister of Social Development. So when you look at the definitions in the act, in every act, it even defines the minister. When you go to the National Health Act or the Health Professions Act, the Nursing Act, the Pharmacy Act, and so on, when it says minister, it's not going to say Minister of Defense. It's not going to say Minister of Higher Education and Training. It's going to say Minister of Health. When you go to the Children's Act, it's going to say Minister of Social Development. So it talks to the minister who is the custodian of that particular aspect. And when it comes to the issues of children, it resides with the Minister of Social Development. That's why it does not say the Minister of Health, but the Minister of Social Development.
Okay. My daughter is not happy here. I don't know what they are doing to her. I was trying to say, please.
Okay.
She's like, wah, wah, wah. She's screaming, you know. I wish we had time because I was going to ask you a different question, but please just note it, but don't respond. Because I wanted to ask you when there's violations of the act or about my child, the suing, do I take it to the custodian of the act or the ABC of Health? But it's because I wanted to see, but
no, I can respond to that. And
yes,
and you use the word suing.
Yeah,
I touched on this earlier. I touched on this earlier. You know, whenever there are violations including medical negligence, you know, we think of the civil courts and so on. And basically it will depend on the nature. As you know, there are different ways to redress any form of negligence. Whether it is just a negligence that did not cause death. You know, when there is a death, we go the issues of the Inquest Act and so on and so on. But for other things, you can also look at the civil court procedures. In other instances, you go the criminal route. In other instances, you go now from a practitioner, as you know, you go to the council. And when it comes to the health facilities, you do have the ombuds, health ombuds as well, where you can go. So there are different ways where you can have a redress of your issue.
Okay. The redress I see, but I want to know who speaks suit. Because remember, when I cut the wrong tube, the claim is not
Yes.
against in public service. The claim is not against the practitioner. They will say the MEC of health, right? That means it's taking the health route. So I'm trying to see if the
Yeah.
law belongs to DSD when there's a malpractice around
Oh,
violations of the Child Act.
I-
To which minister?
the practice
Yeah, you see.
is the Minister of Health, eh? Is
Okay.
the Minister of Health. Is the
Okay.
Minister of Health
But he's not the
in that
custodian. He's
context.
not the custodian of the law, of that law, the
No,
Child Act.
he is the custodian of the National Health Act. Hence, in my list of statutory provisions, I have the
Okay.
National Health Act.
All right. We'll come back to this one. It's a pity we are running out of time.
Okay.
Because I don't know how I can be charged for an act that does not belong to my department. But let's go.
Oh, I see.
Yeah, you see what I'm
get
trying to
you.
get to. Yeah. So
I get you now.
Vagi says when performing a TOP in secret, a clinician didn't consent. What you say secret? I don't know. A clinician didn't consent. Now there is a complication. A clinician is seeking a consent from a parent. Okay, I understand what is. It's a comment actually, but he's referring to the fact that it can be done without
Yeah.
parental consent. But when there's a complication, the parent must now consent to the resolving of the complication. This is confusing. Do you agree with his statement?
Yeah, no, it's true, and this is the case I was dealing with last week. Although there was no complication, because these things sometimes are done in secret. I know of a case. It went to a professional conduct inquiry for that matter, and it was so bad because you have got a situation where colleagues are making favors for friends. You have got a friend who has messed up. The friend comes with the girlfriend to say, hey, let's do this thing. And you do it on a friendship level, and you do not follow the correct procedures. And if that relationship becomes sour and the lady comes on you, you are in big trouble. Try by all means to separate, these other relationships from your professional relationship. When it comes to your profession, protect your profession. This person is correct to say when it's done in secret and there are complications, that is where everything now comes out and hell breaks loose.
Yeah, colleagues, let's take 5 more minutes. If we can take maybe 3 more questions, and I'm sorry that we are not able to take all of them because, yeah. Anonymous says, in the case of children with mental health issues, severe intellectual disability disorder, is it still not allowed under the law to sterilize the patient whilst under 18? Is there some provision that can be made for such cases? I have a small direct answer, but I'm not the presenter. I was going to say go to the courts. I don't know what you're going to say, Dr. Quinton.
No, Dr. Mawela, the act is quite very clear.
Yeah.
When the sterilization can be done. Only when, if you do not do the sterilization, it will be detrimental to that person. And you are correct, Dr. Mawela. You can take anything to court. You know the issue of interpretation of statutes. You can subject anything to the court as long as you have got a case to make where you can even change the law. That's why case law becomes important, because the basis of case law is there a judicial precedent of this section of the act? That's why when we read the law, we don't just read the text that is in front of us. We also look at, is there any court decision that has been made in terms of this section of the act? So while the act says that, you say, this is what the act, do you want to challenge that? Then go to the court and challenge that.
Yeah, but for now, no. And this thing of sterilization, before we even look at it, it's a very sensitive issue because we do find ourselves having beliefs that certain populations must be sterilized. I know in the HIV world, there's still big cases coming through of I don't want to say forced, because some of the patients don't even know that they were sterilized by virtue of the health workers' belief that if you are living with HIV, you're not supposed to be having children, So we must always appreciate why ethics and the law are so important in how we deliver services, so that we don't find ourselves, abusing the power that has been given to us as health professionals. But if you feel the need to deviate, I think go to court, prove your case, go to the constitution,
Yeah.
prove your case. Laws are changed over time, but if it is not changed, you cannot violate it. I think that is the rule. Chisam Piri says, how can EMS professionals protect themselves legally when consent processes are incompatible due to emergency circumstances? Okay, I lost my lights. I think my battery will kick
Yeah,
in.
I can see.
Yeah, something happened.
Yeah, no,
Oh.
I think I'm getting this from our EMS colleagues, because think of it this way, Dr. Mawel and colleagues. You are called to transfer a patient to another facility where they need to do a procedure. It's an emergency, and the consent are not done properly. Now, the issue is that the consent is usually done at the place where the person is going to be operated. But now here's the issue. This child is taken to a clinic or a hospital. The parent are not there, somebody to give consent. So that's why it is important to understand that flow that I described in terms of Section 129 of the Children's Act. So if there is that gap, your role as a pre-hospital professional is to ensure that the person is at the facility where they'll be treated. Now, when they are there and they pick up the gaps in terms of the informed consent procedures, then that order of Section 129, if they understand it, they will follow it and ensure that the child, if they require urgent intervention, they are assisted.
I know that in the, I don't know, should I say in the National Health Act or somewhere, there is a specific section that deals with emergencies, which may
Yeah.
even protect us to respond if the time of the approval would take longer than the agency of the intervention, something along those lines. I know there's a specific
Yeah, is
yeah
that it's there in the Constitution and also in
constitution.
the
Yes,
National Health Act. Yeah.
yeah.
In terms of Section 20, no one can be denied emergency treatment. That you find in the Constitution, in the Bill of Rights, and also in the National Health Act. So you look at all those aspects, and at the end of the day, whoever is the receiving practitioner, if they need to act, they will follow the procedure in terms of the Children's Act.
Yeah, we're gonna close with this one. I know it's sensitive. It's a challenge in the South African setting. I think everywhere. Before you respond, because there's two, they are linked. Sulufelo says, does everything you have said, especially around the forms, do they apply to traditional practitioners? And Gididi says, is there any consent forms for initiates and traditional leaders, especially during initiation schools, especially when underage or younger children are admitted in such schools? There was a lot of questions around this area. Do these acts apply there, or there we look at other things? And your opening statement, you did say when you were outlining the laws, I was listening. When you got to customary, you said customary does not supersede the constitution. I heard you very well. That if it deviates,
Exactly.
So what is the issue
Exactly.
there?
The issue of the Children's Act,
Yeah.
it applies across. It applies across. The only thing is that, I know one culture where you'll never go to a circumcision school if you are not of a particular age. They don't do this thing. I mean, I know in my culture in Chivenda, you can take a 7-year-old man to Hogoni. They go there, and because we believe that the younger you are, the quicker it is for you to heal. Whereas when you are older, you have also got other thoughts and so on. These are cultural practice, and we need to understand that The Children's Act is enacted to protect the child. That's why the Minister of Social Development, one thing that is true is that there are certain, look at our own medical male circumcision. It's done on even less than 16s.
10-year-olds.
It's done for for the purpose of HIV prevention and so on. And some of these things do happen, but all we need to know is that there is a law that governs all these things.
Hey, there's things you don't want to say, I see, but I hear you. I hope colleagues can read between the lines that there's a law and there's the practice. And even if you violate the law, at some point it catches up with you. I think these are the things. Okay, we can, okay, maybe colleagues, and I want to talk to the issue of where the clinical practice violates your religious rights as a health practitioner. Isn't it health practitioners have rights? We'll close with this one.
Yeah.
What is your advice for that? Where there's a practice that violates your own values?
Yeah, that deals with really your religious objection. It is provided for in the Constitution.
Okay.
But you cannot prevent somebody. You may not do the termination of pregnancy. Let me be practical, Dr. Mawera. I'm a practical example because when I was doing internship, my MOs were not happy with me because when I was doing gynae, you know, interns are the ones who do evacuation of the uterus in the afternoon for top. So I had to bring my religious objection to that to say, you know, this evacuation, I can do any other evacuation, but an evacuation coming from a top, I'm participating in the act. So a religious objection, I put it forward, and my MOs on the day when I'm supposed to be in theater had to be the ones who were in theater doing the evacuation, not me. So it is, but here's the issue. If it is an emergency, you need to assist the patient. It's a different story when there is no emergency. When it is an emergency, you are required to assist the patient, irrespective of your religious belief, because yours is to save lives.
Can I ask you, this is a question I had and we'll close with it. Luckily I'm the chair, so you know, we are done, but we are already beyond time. So I want to get to this point. Is there a place in clinical practice, medicine, right, in the interest of the patient to violate or to coerce the patient or to do everything you can do to save the life? You know, you spoke about an ectopic pregnancy. There's Rapchart. It might even be an older person. It might even be an older person who understands. When we talk about this best interest of a person, you know, who interprets it in the, you know, can I make a choice as a clinician to say, for Dr. Kwinda today, I understand he has a tattoo that says do not resuscitate or whatever he has written, whatever the issues are. But in his best interest, I am going to do what is needed to keep him alive. And I'm successful to keep you alive. Will I lose the license? What's going to happen?
When I wake up, I'm going to sue you that you have kept me alive. I wanted to die. But here's the issue, Dr. Mawera. Let's differentiate between the best interest of the child and the best interest of the patient.
Patient versus
those
the
are
child.
not the same thing.
Ooh,
Because when we deal with children, you speak more, even if the child, whether the child is a patient or not a patient, is the best interest of the child. That's what you will find in the Children's Act, is the best interest of the child. Now, coming to the best interest of the patient, you are touching on the ethical principles now. Because when you talk about the best interest of the patient, you are talking about altruism, you are talking about beneficence, which is the opposite of the maleficence. You know, and now when you look at the ethical principles, you have got beneficence, non-maleficence. You have
Autonomy.
got a respect for autonomy. Now,
Mm,
that is where now there is a conflict, and it usually happens in ethics
mm.
that you can have a conflict. It's easy when there's a conflict between an ethical theory and an ethical principle, because an ethical principle will always come above the ethical theory. But a challenge comes in now, because that's exactly what you are describing. There's a conflict between the best interest of the patient, which is an ethical principle, and the respect for autonomy,
Autonomy.
which is
I
also an
know.
ethical
I'm
principle.
going there. My eyes are open. I'm like, I'm sitting with this person.
Now, that is a scenario that you are describing of a conflict between two ethical principles.
Yeah.
Now, you go back to the Constitution as well, because the beauty about these things is that you have got the law and ethics. You are not going to violate somebody's body who is not willing. So in that case, you need to look at both and say, yes, I know what is in the best interest of this patient, but they don't want it. And they've put it very clear that they don't want it. That's why
But
some people say, if the person become unconscious when they've refused, when they were still conscious,
yeah,
can I intervene now that they are unconscious? The
yeah,
thing is, the person has expressed themselves. You know
yeah.
their desire, you know their autonomy, which you need to respect. It's a
It's
two-cake situation, which is
complex. Yeah.
this is what we call ethical dilemmas.
Yeah. Let me tell you, and then we close there. You spoke about religious objection. What if I want
Yeah.
to use my religion for the reason to save a life? I'm not objecting to do a procedure. I'm actually pursuing a procedure on the background that I cannot just allow a person to die if I can save them. I'm the good Samaritan. I cannot just pass by.
Dr. Mawela, when I read my Bible very well, I have learned that in all instances where Jesus Christ also had to save somebody or heal somebody, he first asked them, do you
If they
want to
want
be
to.
healed?
All right. Yeah, no. I was just trying to add some drama there, and spice it up and see how it can go. Colleagues, don't do
Nice
as I was
one.
asking. It was just for learning and for application. And let me tell you, I think what I've learned about ethics, you don't have to carry the burden. Good institutions have ethics committees, they have, those kinds of things, so that
Yeah.
in that moment you can consult. At least it removes the
Uh,
burden on you. Give it to your medical manager, give it to your CEO, give it to the magistrate, to make the call, because these things
Dr.
can be
Mawela,
so heavy. Yeah,
just to share a story with you.
yeah,
I was once invited and called upon to go to, it was Mankweng Hospital in Limpopo,
yeah.
because there was a patient who was in the vegetative state.
Eish.
The nurses and the doctors they were so attached to her
Yeah.
that they could not let it go. And we had to sit now and have an ethical session, because it was an emotional issue. They are so attached to her. They just come in the morning. The first thing they go is to go and greet her. And it was such, and this person was already sitting more than 500 days
That's more than a
in
year.
ICU.
Mm.
Yes, in ICU. So
Yeah,
these are
I
real
can
situations
imagine.
where take that burden, give it to the relevant committees that are in our hospitals to be able to deal with such issues. It can be quite very frustrating.
No, it must have been traumatic for the practitioners. I can imagine. Actually,
Yeah,
at the family level, I've had to be the one who makes such a decision about a very close person. So I know
yeah.
exactly what goes into that. You don't want to be that person. That's all I can
Mm.
say. Especially if you are the one in the family and you are a practitioner,
Yes,
and the clinicians, they are talking to you, they are telling you to go and convince the rest of the family because
of the family. Ah,
and in that it means that Lena, that person, You know, I still love her. You know, I'm still,
Yeah.
Shem, I found myself in a
They're
very
just using you
awkward.
because they know
Yeah,
you understand better than
that's
the
what
rest
they
of the
thought.
family
But I was
members.
like, Shem, what about me? It was not nice. It was an
Yeah.
experience that yeah, you know, it is what I mean, yeah. We had to do what we had to do. So, colleagues, yeah, we have kept you a little bit too long, but I'm hoping that it was a value adding experience that will continue to transform your life and how you care for the people that we serve every single day. All I want to say, remember to join membership, support the clinical care platform. We continue every Tuesday, Wednesday, Thursday. We do have educational programs, but also Saturdays we have our master classes. Dr. Quinda, as always, thank you so much for making time. You are leaving us empowered.
Thank you so much,
And
Dr. Mawela, for the
it was so
invitation.
awesome. Yeah. You know what I want us to
Thank you.
do? I want to I've been wanting to look at the ethical issues in anesthesia. I'm gonna talk to the doctors there
Okay.
if we can have some scenarios around
Yeah.
anesthesia and ethics, and I would like you to be there so that you can, you know, they
Yeah.
can give the
It's
clinical side and you look at
it's a very critical one because of the interplay between the surgeons
yeah,
and the
anesthesiologist.
anesthesiologist, who is responsible for the anesthetic part of the consent.
Yes,
Is the surgeon or the anesthetic? So there are lots of things
somewhere
there that
there. Yeah.
gray
So
areas there. I
I'm
know
gonna
exactly
talk
what
to
you're
them.
talking
So,
about.
colleagues, we're gonna have interesting clinical things, real scenarios, but looking at it from both sides, I think it's going to be very interesting. On that note, may I wish you a restful night with your families. Bye bye.
Thank you. Bye.
Welcome to the Seminars in Clinical Governance and Ethics. Today's seminar focuses on one of the most important responsibilities in clinical practice: consent for surgery involving children. When children are involved, consent must always be grounded in legal and ethical principles that prioritize the child's best interests. Healthcare practitioners carry the responsibility of ensuring that consent is informed, voluntary, and specific to the procedure being proposed. This includes clearly explaining the risks, benefits, and available alternatives. In a Today's discussion will help strengthen your confidence in navigating these complex decisions with clarity, care, and integrity. We're glad you're here.